So dear participants, my name is Maria Pellegrini. I'm the Educational and Patient Program Manager for the ERN-EuroBloodNet, and it's my great pleasure to welcome you on behalf of the whole ERN to the 6th topic on focus on thrombotic microangiopathy webinar for health professionals. As you may know, this program has been developed by a collaboration between the ERN and the French National Center for Thrombotic Microangiopathy, the CNR-MAT, and the whole program will consist of 15 sessions. Furthermore, the program is accredited by 11 continuing medical educational points of the European Board of Accreditation in Hematology. Dear audience, now please welcome with me the speaker of today's session, Professor Marie Scully, and we are going to talk about TTP in the setting of pregnancy. Professor Scully is a consultant hematologist at University College London Hospital and also professor of thrombosis and hematosis. So please, Professor Scully, the floor is yours. Thank you very much.
Thank you very much, Mariangela, and thank you to Paul Coppo for the invitation and also to EuroBloodNet. So I hope that this next 20 minutes, half an hour will be informative, but of course, please do ask any questions. Here's my disclosure slide. So the main learning objectives are to review that TTP may actually occur in pregnancy. And not only may it occur, but what do we do about it? And that patients presenting with pregnancy-associated TTP are more likely to have late onset congenital TTP. That is the first time that it presents itself clinically. And women with a history of TTP can be supported successfully through further pregnancies following previous TTP episode. So going back to some basic pathophysiology, which I'm sure you already know about, the normal coagulation pathway for VWF platelets ad amps is that VWF is essentially a globular protein which under high shear extends, and at that point, and with quite a lot of specific steps in between, there's cleavage of the VWF into various sizes of multimers. And it's these multimers, particularly the medium and high ones, for which platelets attach, and is actually primary hemostasis. It's very, very important. Unfortunately, if we have a ADAMTS13 deficiency, which is either congenital, so a patient is born with it, or acquired immune mediated, so antibody driven, failure to break down VWF, even under high shear, results on the enfolding of much larger multimers, which results in excess platelet binding. So therefore, when a patient has a platelet count which is reduced, it's not that their platelets are actually low in the body, they're just in the wrong position. So let's have a look at what we understand to date about TTP in pregnancy. And this indeed is work from my French colleagues. And they looked at 592 adult TTP cases. And within their large reference group, 42 had pregnancy onset TTP. And they found that 10 of those patients, i.e. 24%, indeed had late onset congenital TTP. And what I mean by that is they may not have had previous acute or medical exposure, re-diagnosis of congenital TTP. And then the group went on to look at some really important data, which was back in 2015. It was a long time ago now, it doesn't feel that long ago. And essentially nearly 9,000 deliveries. And within that 9,000, they found 79 women with a platelet count less than 75,000. Now, consider that a low platelet count in pregnancy of around this level could be gestational, a bit low for gestational, but could be, maybe immune, and more likely to be related to other pregnancy-associated hypertensive diseases. So on its own, not necessarily an abnormal factor. And they did ADAMTS13 testing in 50 of the 79 patients, and they found 4 cases with ADAMTS13 levels less than 10%. So essentially, the outcome from this work is that 5% of women with a platelet count less than 75,000 in pregnancy had congenital TTP. So does that matter? As I said, thrombocytopenia in pregnancy is really very common. And in fact, this is so important, it should alter pathways within obstetric hematology that we consider congenital TTP in patients who have a progressive decrease in platelet count. So what about the normal state? We must consider that TTP presents in the 3rd, 4th decade of all the patients, but given that it's more common in women, at least 50% of patients with TTP are of childbearing age. Furthermore, in normal pregnancy, which I'm sure you all know, factor VIII and von Willebrand factor increase. So they increase to be highest within the 3rd trimester and remain high, only starting to decrease thereafter in the postpartum period. And there is a reciprocal decrease in ADAMTS13 activity. Now, this does not mean that the levels of ADAMTS13 will be low enough to present with acute TTP, but if you consider ladies with congenital TTP who've never had a continuous hit for 9 months, you can see that the ADAMTS13 that they have present that normally is satisfactory, albeit very low, is just not sustained. And that's why they start presenting usually in the 2nd trimester or the 3rd trimester. So pregnancy-associated TMAs are very difficult, and they're very difficult because you've not only got conditions that can be precipitated by pregnancy, but you've also got those thrombotic microangiopathies that are primarily associated with pregnancy, such as preeclampsia, HELP, acute fatty liver of pregnancy, and also atypical HUS. Now, within this diagram, it kind of tries to give you when the conditions usually present. TTP can present from the 1st trimester, and actually so can HUS. We mainly associate HUS with the postpartum period, and that is true in about 80% of cases, but it can present here or in the 2nd trimester and can be associated with intrauterine fetal deaths. Preeclampsia doesn't normally start, let's say, till about 28 weeks gestation. Sometimes we have cases that are a little bit earlier, and we also can see cases in the postpartum period. HELP, hemolysis, elevated liver enzymes, and low platelets typically presents in the 3rd trimester. And acute fatty liver, which is a very distinct condition on its own, it's extremely rare, it's extremely severe, associated typically with multi-organ failure, disturbed coagulation, low fibrinogen, and related to a specific enzyme deficiency, LCHAD. And then, as always, There's some thrombotic microangiopathies for which the underlying diagnosis remains unclear. So how do we treat these TMAs? If it looks like it is TTP, the mainstay of treatment is plasma exchange as soon as possible. With preeclampsia or HELP, we need to ensure that patients are monitored and receive supportive care. And by that, and typically, I mean control of their blood pressure. The platelet count usually increases after delivery for both preeclampsia and HELP. And typically this would be within 48 hours. But if we have a patient whose platelet count is decreasing despite an obstetric diagnosis of preeclampsia or HELP, and if less than 50,000, definitely, we should question whether in fact it could be TTP or HUS. And the reason for that is that both TTP and HUS may have features suggestive of preeclampsia, so high blood pressure, proteinuria. There may be abnormalities in the liver enzymes, which are not fully in keeping with HELP, but could be related to one of the other pregnancy-associated TMAs. So if there's any doubt what's happening, it's better to initiate plasma exchange and get an ADAMTS13 activity level. As I said, HUS is typically in the postpartum period. And again, it may not be immediately obvious, and it may look like TTP, which is absolutely fine, and plasma exchange is the mainstay of therapy. However, we do have complement inhibitors, primarily eculizumab, for which there is fairly good safety data, both in PNH and now in HUS, as to the use of eculizumab in pregnancy. So let's have a look at some of the symptomatology that patients may present with either congenital or acquired TTP, and this is from the UK registry. So acquired is red, congenital blue. The mainstay of symptoms for congenital are kind of neurological, renal impairment, significant. They may have more proteinuria, more high blood pressure, but that's probably because it kind of goes on for longer, as opposed to acquired, where it's far more acute. And with that, patients with acquired immune-mediated TTP are more likely to present with an acute collapse plus or minus a coma. But otherwise, it's relatively comparable between the two types of TTP, i.e. you couldn't differentiate based on symptomatology alone. So, management of a patient presenting with acute TTP in pregnancy. So we need to look at a blood film, we need to do a coagulation screen. LDH is really important. So LDH in pregnancy is normal unless associated with situations where there is cell death. Retics, LFTs, and refer to a specialist centre, not only that undertakes apheresis, but also that has obstetrics and neonatal care. Samples need to be sent for ADAMTS13 assays, and plasma exchange continues until TTP is in remission. So the ADAMTS13, if it's TTP, is likely to be less than 10 international units per deciliter. And that doesn't tell you one way or another whether it's congenital or immune-mediated disease. Congenital TTP is more likely to achieve remission quicker, but it isn't always the rule. They can actually become very, very unwell in pregnancy. And you wouldn't necessarily be able to diagnose this in real time. So further immunosuppressive therapy may certainly be required. And the best treatment at this point is steroids, which obviously are broken down by the placenta and don't affect baby. So we looked a number of years ago at the acute TTPs in pregnancy in 35 women. Of these, 23 had congenital TTP provin and only 12 immune-mediated TTP. There were more pregnancies within the congenital cohort than those with immune-mediated disease. So looking at the trimester of presentation from the UK TTP registry, you can see that they actually, regardless of whether it's immune or congenital, can present within all three of the trimesters and are more likely in the third trimester or immediately postpartum. If we look at the fetal outcome in previous and presenting pregnancies, so again, blue here is for congenital, for live in congenital disease, and red is for babies that died. And you can see within the congenital cohort of cases, the chances of an intrauterine fetal death is particularly prevalent within the second trimester, some within the third trimester, but babies are more likely to live if they get to that point. Within the index case, the number of deaths was significantly reduced in the second trimester, and the live dead rate was relatively equivalent, often presenting with the diagnosis of TTP after an intrauterine fetal event. The histology of the placenta is extremely important. It does tell us quite a lot. The first important thing is that it's no different from any other ischemic thrombophilic disorder. So there's nothing that would pinpoint the placenta to suggest that it is associated with congenital TTP. Secondly, the infarcts in the placenta are at different stages of maturity. So it's a continuous process throughout pregnancy. So in the untreated or presenting pregnancy, there are numerous maternal complications. That can be neurological, cardiac, hypertension, renal impairment, and placental abruption. And for the fetus, we have problems with preterm births, growth restriction, and developmental delay on delivery. You can see within this diagram, for those women presenting with late onset congenital TTP in pregnancy, this was the death rate associated with in utero fetal deaths before they were diagnosed. It was reduced in the index pregnancy, but subsequent pregnancies were not associated with in utero fetal death. And why was that? The reason was, very quickly we ensured that all pregnancies of women with congenital TTP were associated with regular treatment. And that was as soon as the diagnosis of pregnancy was confirmed, they started with at least 2 weekly 10 mils per kilo of plasma. We use Octaplas, which is a replacement source of ADAMTS13. Given what we know about the second trimester and the death rate, the fetal death rate, but also in conjunction with worsening non-overt symptoms and a trend for a decrease in platelet count and a slight increase in LDH, typically by the end of the second trimester, at the latest, the beginning of the third trimester, patients are moved to weekly plasma infusion. If their condition continues to deteriorate, we would instigate plasma exchange, e.g. weekly. And sometimes it's not possible to continue with plasma because of reactions. And we have managed some ladies with intermediate purity factor 8. It is not ideal. They're all on low dose aspirin. And typically they're all on prophylactic low molecular weight heparin. And if you go back to what I showed you from the placental gross findings, I think the rationale for this therapy is self-explanatory. Even though we're going to be replacing ADAMTS13 and keeping their bloods within the normal range, there is still the risk of microthrombi continuous formation during pregnancy, and we have to prevent that as much as possible to ensure the best fetal outcome. All ladies are monitored in a specialist obstetric unit, and that includes regular scans, rebirth rate, any issues regarding size, and uterine artery Doppler measurements. We organise a planned delivery. We rarely have ladies going beyond 37, max 38 weeks, and monitor and continue treatment during the postpartum period. So this is some histology. This is from histology from the placenta of a baby that died in the second trimester. And this is histology from a lady who had continuous treatment throughout pregnancy and delivered at term, 37 weeks. And you can see, regardless of what we're actually looking at, there was distinct difference, and this one looks much better. Now, we know within the ADAMTS13 gene that there are no specific hotspots with regards to abnormalities in patients with congenital TTP. However, the vast majority of ladies who present in pregnancy have this C-terminal abnormality, R1060W, within exon 24. It is very, very common, not only in the UK, but internationally. And that may be homozygous or compound heterozygous with a gene in any other exomic region. So it's just not us who have identified the benefit of therapy using ADAMTS13 replacement with plasma. This is more recent work from my Japanese colleagues who looked at 60 patients with congenital TTP. 16 female patients did not have pregnancies, and there were 23 males. So that left 21 female pregnancies, females with 38 pregnancy, excluding miscarriages. So they divided the patients up into two groups. Group 1, 12 pregnancies following a diagnosis of congenital TTP. 10 had prophylactic infusions, 2 did not. 9 of their babies were alive that had the prophylaxis, and 1 died in utero, and without any infusions, 2 were alive. Group 2 is 26 pregnancies preceding a diagnosis of congenital TTP. 3 had plasma infusions, 3 babies alive. 23 without plasma infusions, 13 intrauterine fetal deaths, 10 alive. So there is some level of variability even between pregnancies for women, and it can be that if there's not a problem with the baby, the ladies themselves may have end organ damage, and that's typically TIA, stroke, severe depression, renal impairment, or cardiac disease. So these graphs regarding overall survival rate are really, I think, quite convincing. So the overall survival in group 2, that is preceding diagnosis of congenital TTP, is far less than those that are managed following a diagnosis of TTP. And in the bottom graph, we can see regular plasma infusion was associated with a far better outcome than no treatment. So that's congenital TTP, but let's consider those ladies who have the more common immune-mediated TTP presenting in pregnancy. So again, we have the risk of intrauterine fetal death, typically in the second trimester in the presenting pregnancy. But we can manage those ladies, so that risk significantly reduces. So it doesn't mean that ladies won't have complications and need to be regularly reviewed, But obviously the want and the need to proceed with a further pregnancy is very important, and we have to ensure best care available. Firstly, we have to counsel them. The most important thing is to ensure the ADAMTS13 activity is as high as possible before a pregnancy. Their outcomes are much better in this situation. So in some ways, it has to be more planned than with other ladies. They need to be in a tertiary referral centre for TTP. We need to have shared care with specialist obstetrician and neonatologists. We do start low-dose aspirin, and/or we typically do give low molecular weight heparin thromboprophylaxis. So this is a lady who I looked after many years ago. It was one of the first TTP patients I ever saw as a junior doctor. And she'd had 2 pregnancies in another hospital and had a terrible outcome. She lost both in the 2nd trimester. And it wasn't at a time that one was monitoring ADAMTS13 as closely as we do these days. She then moved to where I work now, and we reviewed her ADAMTS13, and her activity was undetectable, and she had a really high antibody. So we tried with rituximab. We gave her rituximab to see if it had any benefit, and it did. It reduced the antibody, her activity went up and then dropped back down, so we gave her a bit more. And at that point, we started to detect measurable ADAMTS13. So we managed her then through a live pregnancy, and that was very successful and straightforward. But she did throughout that pregnancy have plasma exchanges every couple of weeks. Don't forget, this was back in the early 2000s. She then went on quite quickly to have a 2nd pregnancy, for which we didn't give her any treatment. All we did was monitor the ADAMTS13, and you can see that the level just before baby was born started to dip, which is what we see, but did not go down to very low levels, and she didn't relapse. So she had an excellent outcome with regards to 2 live children. So the final group is those women who've had a previous episode of immune-mediated TTP who want to have a baby. What is their risk of developing TTP during pregnancy? There is a risk, and all patients have to be counselled about this, but essentially they're managed in the same way as ladies who actually have TTP associated with pregnancy. So they have baseline ADAMTS13. We monitor at least every trimester during pregnancy. We have regular fetal scans, uterine artery Dopplers. We manage labour a bit more than we normally would, unless everything's absolutely fine and then they go into labour on their own. But then monitor during the postpartum period. It's another critical time where we think, oh, we've got through pregnancy and everything will be fine, and then they relapse in the postpartum period. But what if their ADAMTS13 activity does decrease? And I mean really quite low. We can consider some low-dose aspirin, because if you have a reduction in the ADAMTS13 activity, it suggests that there will be some ongoing microvascular thrombi, and we know that more and more these days. We can use azathioprine or steroids very safely. Occasionally, if it drops very low, we've resorted to plasma exchange, for example, weekly. And some people have used rituximab. We haven't used it. We probably would if it was an acute relapse. A mum was affected and couldn't respond to standard plasma exchange and steroids. But usually we reserve this till the postpartum period. And we don't use caplacizumab. It's too small a molecule. We would only use that in the postpartum period after baby's born. And we mustn't forget that a lot of the therapies, particularly rituximab and Capla, means that ladies won't be able to breastfeed. So in conclusion, late onset congenital TTP presenting de novo in pregnancy is more common than immune-mediated antibody type of TTP. And fetal outcomes really do depend on prompt diagnosis and treatment. So we don't need to immediately deliver ladies for TTP to go into remission, which is different to preeclampsia and HELP. We still have to continue therapy for TTP, whether we deliver baby or not. But successful outcomes are possible with both types of TTP, but it does require management in a specialist centre. In immune-mediated TTP, the baseline ADAMTS13 activity may help to identify likely relapse. So those ladies with the lower levels at the beginning of pregnancy are more likely to have an acute TTP episode somewhere during pregnancy or the postpartum period. An elective plasma exchange can be considered in women who drop their ADAMTS13 down to about 10 or 15 international units per deciliter. In congenital TTP, I don't think anybody would argue with the requirement to ensure regular ADAMTS13 replacement throughout pregnancy, currently with plasma infusion, and also the use of low-dose aspirin and thromboprophylaxis to reduce complications related to placental thrombosis. So that's all I've got to say. I hope you found it useful, and I would be delighted to take any questions.
Thank you very much, Professor Scully, for this exhaustive and comprehensive presentation. Very interesting. So thank you for the excellent presentation. So I echo the same. How often you perform regular PX in CTTP?
Oh, not often. I just think that we mustn't forget that it is an option, because we're used to congenital TTP just requiring plasma infusion. But I mean, if a patient becomes, you know, unwell and the platelets are low, you can deliver more ADAMTS13 by plasma exchange. So we've had to do the odd one at the end of pregnancy for congenital patients if they look like they're deteriorating, but it's not commonly used. I mean, acutely, yes, you know, before diagnosis, because you're not going to know that it's congenital or immune-mediated.
Okay, thank you very much. So I go to the next questions. How do you see RIDMTS13 treatment in the setting of TTP related to pregnancy?
Oh, it'd be fabulous. It'd be so easy. You know, you go from 600-800 mils, the complications of plasma infusion, to 10 mils of pure enzyme every 2 weeks, every week. It's so much easier. You can do it in the clinic room.
Okay, thank you. When do you recommend to start regular plasma prophylaxis in pregnant women with CTTP?
So as soon as they become pregnant, if they're not on regular prophylaxis already, they need to start it as soon as pregnancy is confirmed, because the risk of developing microthrombi is obviously over the course of pregnancy, so sooner rather than later. And actually, in at least, certainly in the paper that we did quite a few years ago, but we found at that time about 20% of patients after diagnosis needed to continue with plasma infusion because their platelets just dropped every couple of weeks, 2 or 3 weeks. So it's almost, you know, the starting point for the need for ongoing therapy once they present in pregnancy.
Okay, thank you very much.
Can I ask the audience a question?
Sure, I can unmute the audience.
Okay. How many of the audience have looked after a patient diagnosed with TTP in pregnancy?
Just to answer Marie Scully, so yes, we did not look at patient directly, also because I'm not a physician but a biologist. I can say that from Switzerland, we did not have any patients that we could follow pregnancies. We had some cases in the US where we collected the data and we saw that the pregnancy, as you said, the prophylaxis was started as soon as possible, and the pregnancy had a good outcome. And through the entire kind of registry, we observed that before the diagnosis of congenital TTP, most of the pregnancies didn't have a good outcome. So with several problems, miscarriages and etc. But so far, as soon as the patient is introduced to prophylaxis treatment, or the treatment is adapted to the pregnancy, then the outcome is normally quite good. So, yeah.
Thank you. Yes, thank you. There's another couple of questions here. Does the pregnant woman have to stay in ICU when they have to have plasma exchange? No. I mean, ICU is really for when they're clinically unwell, not just because they have plasma exchange. And the plasma volume that you use for plasma exchange in pregnancy, well, as a prophylactic thing, we would only use a single volume. If they were acute, we'd start off with the 1.5 volume. So single volume is 40 mils per kilo.
And I see another question. Thank you very much for your presentation. It has been reported that for TTP patients, the occurrence of preeclampsia may be increased in subsequent pregnancy. Do you share that observation?
Yes, certainly. Having an increase in blood pressure is very, very relevant. However, that can be reduced in the congenitals by the regular ADAMTS13 replacement, and in the immune mediated, ensuring that their ADAMTS13 level is kept increased. And with those measures, that certainly significantly decreases the preeclamptic risk. But in the index pregnancy, preeclampsia, what looks like preeclampsia, is definitely an associated phenomena.
Thank you. We can close the session. By the way, the presentation was really exhaustive and we have received very good questions. So I want to thank both the speaker, the Professor Scully, and the audience for this great exchange. So thank you very much.
Thank you, everybody.